it was more so that the communistic aspect that stuck with me.
All right, thank you. All right, so thank you everyone for sharing your experiences. I appreciate it. So we're gonna switch gears a little bit. This image, whenever I look at it, it sort of makes me just think of like a spiraling out of control as a physician experiencing this grief over and over again with multiple patients. I think common sense would tell us that these are different relationships. We probably don't experience grief in the same way as someone would for their own loved one, but still, like, that effect has a toll on you, patients over and over again. And I think it's a really interesting concept of how do you become numb enough and distance yourself enough to continue to do your job, but still not become burnt out and lose all your empathy. So one method that has been proposed to improve our training on this topic is, of course, SIM. This is the first study I want to talk about was done with resident physicians. This was a randomized control trial. So residents were randomized to 2 different groups. The first group was a patient that presented in distress and then proceeded to arrest. The second group was a patient that presented just in arrest. And both groups were required to tell the family members of this sudden death and notify them of it. And both groups reported high levels of satisfaction with this type of learning. Interestingly, the group that experienced the distress to arrest reported more stress, but then afterwards reported even more satisfaction despite having that higher level of stress. A second study also is sort of similar, this time with multidisciplinary teams, physicians, nurses, staff. And this time, the SIM case was the same. It was a patient with Brugada that went into VFib. The groups both shocked the patient, and then after 3 shocks, they were randomized to either have ROT or asystole. And again, we're required to notify about the death. So there were no difference between the groups in this study, but both also reported high levels of satisfaction with the learning environment. And also decreased anxiety regarding their death anxiety, which is actually a little bit of a nebulous concept to me, but apparently it's something you can measure. All right. Okay. So debriefing. So we touched on this a little bit already. The debriefing that tends, so I guess maybe we've had different experiences here. More of our attendings are just better at doing this, but in the surveys that I read, most people report not doing debriefing at all. And when they do it, it tends to be more of a what went wrong, what's going on with this case, and we do more of an M&M kind of style format. So there are a couple studies out there looking at more of an emotional debriefing session after patient death. The first one was done at MSK very recently, actually. So I don't know if any of our EMIans actually participated in this, but it looked at internal medicine residents on their 4-week oncology rotation. So over the 4-week block. So the residents participated in debriefing sessions after a patient death on the service. These sessions were 10 minutes long. They happened about 24 to 48 hours after the death, and they were performed by attending physicians who received no prior training but had these little pocket card things to conduct the debriefing. And again, high levels of satisfaction, high ratings of educational value, and also just really appreciative of the attending support that they received. The second one was out of John Hopkins, out of the Pediatric Palliative Care Center. This looked at debriefing sessions over a 3-year period, so there were over 100 that were performed. These were done on a voluntary basis, coordinated by their bereavement coordinator, and done about a week after the deaths occurred. Interestingly, people who chose to attend the sessions tended to be nurses, tended to be female, and of the over 600 participants, only 15% were physicians. The surveys at the end of this 3-year period were, again, overwhelmingly positive, and often reported improvements with their grief. Granted, this one I think is a little bit more limited because people who chose to go to the sessions probably had an inherently different coping style than those who didn't. So, didn't realize before this that debriefing is a little bit controversial, but not in the sense we think of it. There's been studies on critical incident stress debriefing or psychological debriefing after traumatic events. There was a Cochrane review that looked at all of these and basically concluded that this is not something we should be doing. It doesn't help, or it makes people have more symptoms of PTSD. I'm sorry. And this is a different type of debriefing than we would attempt to do, so I don't think it's 100% applicable, but still sort of interesting. And then I think lastly there are some, maybe what you would call more common sense, everyday, kind of beyond formal training, things that we can do to kind of help ourselves cope with these situations. Most of this comes from a resident perspective journal article out of Annals of Emergency Medicine. The authors of this study suggest that maybe look at your coping styles, think about your past experiences, what you've experienced loss, whether it's patient, family, how that affects you, and what you're bringing to the table every time you experience a patient death. They also encourage us to think about what meaning we give to suffering, what meaning we give to end-of-life issues, and life in general, which I think is not an easy topic, but definitely something to consider. And then just think about people that you look up to, think about people you think have positive coping styles and have shown you those in the past while you've been working, and to try to emulate that. All right. So overall, our take-home messages, we as physicians experience very strong grief reactions. We know that new trainees respond well to attending support. Don't be afraid to show your grief. It doesn't mean that you're weak, and support your colleagues. Anyone have any questions? Yes, Dr. Silver.
So actually, you guys know I read a lot of weird stuff in my free time. There was a really interesting article, and I pulled 3 others on it, that said that PTSD has a lot to do with visual memory, because images repopulating in your head. And there was 2 good studies, and maybe 2 or 3 others that weren't so great, but they said that if you play Tetris after a bad event, the brain function that's used to figure out where the blocks are going is the same brain that lays down PTSD memories. And if you can clog that brain and not let the memories get laid down, clog PTSD. I don't know if it works for all video games, but Tetris only blocks PTSD memories.
Interesting.
And I do know that article too because Will, one of our prior residents, has some issues with it. I also want to say that the literature that you quoted about debriefing and PTSD is not very good for emergency medicine, and especially in the disaster literature that we're finding more and more that there's a population that debriefing does not help them at all, and in fact makes it worse.
Yeah.
And that you need to offer it after a traumatic event, and people need to be able to opt out of it. So for some people, it's a really good idea to sit down and get touchy-feely like I like to do and all of that. And other people, it's a really bad idea. And so you really need, if somebody says, thank you very much for offering me this, but I don't want it, then you really need to listen to that. And I think that's a really important aspect of this whole debriefing thing. The other thing that I think is really important to everybody in the room is the culture, and I'm seeing a change in 20 years, of talking about advanced directives, talking about is changing. It's changing a little slower here in East Flatbush than it may be from some other places in the country, but it's going to become much more of a conversation as you guys go forward and are training more and more people. You're going to be able to have that conversation far more readily. I mean, the whole concept of quality versus quantity of life is changing very drastically, very quickly in the last even just 5 years. So you need to remember that you're kind of on the cusp of this change in conversation of what are the goals of life, what's going on with it, because if you have patients that you can do that with, it becomes a very rewarding experience over the patients that you can't do that with. And the last little comment I had is I had one of the worst cases I had ever when I was doing trauma. And it was a woman who pretty much got, a total brain injury from being on a Vespa and getting hit by a truck. And about 5 days later, I got a call from her family because they were having a memorial. And they had a list of everyone that had received a transplant as a result of her donation. It was 22 people. I mean, it was really an amazing experience. I chose very actively not to go to the memorial service, but I was really impressed when I got the letter saying, thank you for facilitating this transplant. And these are the kidneys, the lungs, the liver. I mean, she was pretty young and in pretty good shape. So just there are weird ways that it comes back to 2 or 3 days later that I actually have a pretty good feeling about this particular case, whereas I probably wouldn't for a person. And then the very, very last thing, I promise, is that people can be completely ready for deaths, and they can be dying of cancer and knowing they're dying and dying and dying and dying, and they're still not ready. So just remember that family, even though they've known about it for 6 weeks, 2 months, 3 days, and then just coming into the emergency department, basically because they don't want them to die at home, they still aren't ready. So just remember that part, because people are ready and they're not. There's just nothing like, when somebody's dying and when your actual mom or dad or brother or sister dies, you're not ready. And we got to be really patient with those people, because how could you have not known? I'm looking at this, which was a corpse for 5 days before they got here. And that family just doesn't get it. So those are the 2 comments I have. But the PTSD and debriefing literature is pretty important to me. So you offer it, but don't demand it. Thank you.
Dr. Willis?
Tell me, I don't want to put you on the spot, Nicole, but is there anything from your reading that you could give pointers or just key points for debriefing?
I think it was because of that, well, maybe I'm misinterpreting this, but the sense that I got from, because of that PTSD literature, was that you want to sort of focus on the reactions of the case, your emotions, think about the family, think about the patient in an emotional way rather than in a just sort of a medical, factual way.
I just had one more comment about that and debriefing and offering it, but if the person is not ready to or is at that point. I had a day on the medicine force where I had 3 deaths within maybe 2 hours. And for me, and another member of my team was expected, and I don't think we were bothered by them, but one of my interns was to show. And the attending was forcing her to have this conversation at a time where she was not anywhere near ready. And I think made it much more traumatic for her, putting her on that spot at that time. So just, making sure that it's the right time for that person and doing it at the right time. Because I think that she probably, I could tell she was very, very upset by that process. So they were trying to do the right thing by acknowledging it, but it was making it worse. So just definitely thinking about offering it and always offering it, because I think there's a lot of times it's not offered when maybe it should be, but just it can make it much worse.
I think that's just another good point to emphasize that it doesn't necessarily, not asking the questions isn't necessarily what needs to be done. It's sort of the sense that there is support available helps a lot, and the sense that you don't have to hide your grief. It is not shameful to be upset about a patient death is important.
And we can always debrief it with us now.
Without them.
Yes.
All right. One more thing I forgot to mention was that oncologists and other people who have more kind of lasting relationship with patients often attend the funerals or send cards. I don't think that is really applicable to us, so I didn't emphasize it. It's we don't have that rapport with patients, but it's something I thought was interesting. And then, since this is sort of a depressing, intense topic, I want to just end with one of my favorite quotes from one of my favorite shows. If all else fails, there's never been a sadness that cannot be cured by breakfast. Thank you.